Pharmacoepidemiology and Pharmacoeconomics Research Unit, also known as PEER. He has many accomplishments to his credit, but in the interest of time, I'll highlight that his main research interests include the evaluation of efficacy, comparative effectiveness, and safety of medications used to treat rheumatoid arthritis, spondyloarthritis. He's in 2012 was the Henry Kunkel Young Investigator Awardee by the American College of Rheumatology. And I've been very lucky to have his mentorship in my career path for the past few years now. And today's Grand Round topic, I think, is very timely, very relevant, entitled ACR COVID Vaccination Guidelines and Other Considerations for Preventable Infections in Rheumatology Patients. So thank you, Dr. Curtis, for taking the time to talk to us today, and welcome.
Thank you so much. It's a delight to be here and certainly a privilege and an honor. Sad that I can't be there in person, but obviously COVID has wrecked many things, travel not the least of which. So I hope to be able to meet people in person or catch up with you individually, even over Zoom later on today or later on this week in the times that we have scheduled. So these are my acknowledgements and disclosures. As Namrata mentioned, I serve on a couple ACR task force panels related to the COVID vaccine guidance and a more general guideline task force, and I'm going to speak to some of the things related to vaccination today. I'm going to start with influenza and pneumococcal vaccination, and then move on to shingles, and then probably speak to the thing that has the least amount of data, but probably is occupying the most attention for me and all of you as well, and certainly that of our patients related to COVID vaccination. So by way of reminder, let's start with influenza vaccination. So probably we're all familiar with the different types of flu vaccine. There's a standard dose, which is the trivalent. It'll cover 3 serotypes. There's the high dose that is recommended for age 65 and above. So if you use that, there's 4-fold antigen, and there's an intradermal option. And that's been shown to have improved clinical efficacy in older patients. And so that probably is the one that you want to give to older individuals, but perhaps immunosuppressed patients. And I'll show you some data in that regard.
With Dr. Curtis,
yeah.
Sorry, we can't see your slides.
Oh,
it doesn't look like they're shared any longer.
Oh dear, thank you for interrupting me. Now,
perfect. Yes,
now
that's great. Mm-hmm.
Okay. Okay, so these are the acknowledgements and disclosures. Now are we good?
Perfect, thank you.
Okay. There's an intranasal option, which was previously preferred for younger and healthier people because it's a live virus vaccine. The thought is maybe it will work better. You and I as rheumatologists would not want to give this to anybody who's immunocompromised or that has an immune-mediated inflammatory disease. In fact, for a while, the CDC said this doesn't appear to work and nobody should get it. That they've reformulated it, and it's now okay, although not preferred even for healthy people. But again, you would stay away from this one for anybody who is immunocompromised or is older. There's the quadrivalent vaccine, and so that would cover 4 strains of the flu, and I'll tell you, a little bit more why you would care about that one. There's also now a new high-dose quadrivalent that's approved in 2019, and then just to make things really easy, there's yet another option that's an adjuvanted. So it has a different mechanism by which the immune system is stimulated. That one was new in 2017. And then for those that have egg allergies, there's recombinant options of all of these things. Who should get this is really everybody. And certainly all immune-mediated inflammatory disease, all rheumatology patients. And so this is something that, of course, has become a quality of care metric by the ACR and a number of other groups, even within rheumatology. So depending upon how you all are approaching MIPS and how those in community practice are doing so, this is one of the things that you could choose to decide, you as a rheumatologist are taking good care of patients in a quantitative way by adhering to appropriate vaccine schedules for both flu and pneumococcal vaccination. So this isn't only a primary care thing. There's obviously a lot of options. I think a lot of people, though, might actually not even remember, oh yeah, there's a lot of choices, and like we have to pick one at the beginning of flu season. If you're not the person who is in charge of ordering this or choosing, you probably at least want to know, if not have some input into which you're choosing, because it will probably matter. I know that our clinic at UAB generally runs out of, or at least has constraints on, the high dose flu vaccine for 65 and older. And so in my practice, I often tell people, I really want you to have the high dose. If all we have is the standard dose, tri or quadrivalent, I'd prefer it if you delay and we come up with a plan about, where my patient is going to go get it. But some of the differences, in fact, matter. And I definitely would prefer the high dose for the people for whom you can get it. The vaccine effectiveness, unfortunately, varies a lot. And I suspect that a lot of patients have a sense of this. When the epidemiologists and infectious disease virology folks, formulate this, when they guess wrong, it's only 10 or 20% effective. And when they guess right, it's 50 or 60% effective. And the reason I show you this is both to remind you that the relative effectiveness of this is in fact the lowest really among any of the vaccines that we use, but also to help you compare and contrast for your patients who frankly might be on the fence about getting, either a shingles vaccine, if you choose to give that, or the COVID vaccine, where, at least in healthy clinical trial volunteers, the shingles and the COVID vaccine is not in the 10 to 20, and it's not even in the 50 to 60% range. But as we're going to talk about over the next 30 to 45 minutes, it's in the 90 to 95% range. So quite a contrast from influenza vaccination. The quadrivalent is also important. So I've given you, where we have the most ample data from the 2019 and 20 flu season, the epidemiology in the most recent year from a lot of infectious diseases has been rather marred by COVID, as you might expect. So what I'm showing you is the subtype of the flu strain. So remember, there's 4, H1N1, H3N2, that's orange and red respectively. And then the green ones are the B strains, Victoria and Yamagata. The reason that you care is that if you are not giving the quadrivalent, you're actually going to miss one of these 4 strains. You're going to miss the green one that's the darker green. Is this a big proportion of all influenza? No, but is it trivial? Probably not. So if you're only giving the trivalent, not the quadrivalent, your patient is not protected against the dark green strains from Yamagata. That was last year, and in fact, although they don't have as precise subtyping this year, the proportion that are B strain, of which, some of that is going to be the 4th serotype, it's going to be the one that is hit by the quadrivalent, but not the trivalent, B has assumed greater importance in this year's flu season than it did last year or in several of the prior years. So my point is that if you're going to vaccinate people, try hard to get the quadrivalent. Some years it's a modest contributor, other years like this one, it's a larger contributor. So if you have a choice, pick the quadrivalent. And then, not surprisingly, but there is rather scant data on clinical effectiveness in rheumatology patients. But this was a nice population-based study out of the UK, looking at folks with rheumatoid arthritis, spondyloarthritis, lupus, etc., on immunomodulators. They then linked that to United Kingdom hospitalization data, showing that there was a significant reduction amongst the vaccinated in pneumonia and COPD and respiratory hospitalizations, as well as pneumonia-related death. And I show you this just because what I'm going to get ready to tell you is a whole lot of lab-based studies, and it's nice to actually have some confirmatory data saying we're actually preventing the kinds of infection that we hope to. These aren't just going to be lab-based outcomes, which is what most of our field has available. So that said, the clinical efficacy data is rather scant for most of the rest of this talk, and frankly, most of our field. The outcomes that we have are not what I just showed you. They're not influenza infection or pneumonia infection or even respiratory hospitalizations. They're mostly lab-based. And there's a lot of variability in the definitions used for response. Some studies might use a rise in titer, so-called seroconversion. You measure a baseline, you measure something 4, 6, 8 weeks later, you're looking for a fold rise, 2-fold rise, 4-fold rise. That's seroconversion. If you knew that there was an absolute level of protection, the antibody level is above whatever, that's seroprotection, you could report the proportion of people that achieve that. The number of antigens tested, if it's a quadrivalent vaccine, then you can test up to 4. But how many do you need to achieve seroprotection for to say that somebody's a responder? You could pick 1 or 2 or 3 or 4, and I'll show you something where people couldn't decide, so they did all of it. And then the timing of the outcome assessment is variable. Should we measure 2 weeks after vaccination or 4 or 6? There's not really a standard. There's some common conventions, but there's a lot of variability. And I remind you of all this simply because it's relevant not only for this literature for influenza and some of the other vaccines, but it's going to be really relevant for COVID vaccines, where we don't even have the same vaccine platforms. And yet, if you want to know how well do these vaccines work, we're going to have all of this heterogeneity that we have to interpret and make sense of between different vaccines, different treatments, different diseases, and different vaccine platforms that we're going to have to deal with some of these things. There are very, very few, if any, head-to-head studies looking at the influence of, treatment A in rheumatology versus treatment B. So, TNF versus rituximab or abatacept or a JAK drug, etc. My colleague Kevin Winthrop and I, as well as some other investigators, have put together a table like this and a newer one that we published a few months ago, trying to summarize really the entire field's literature about which of our medicines do what to different vaccines. Now, again, mostly these are lab-based outcomes. You see that rituximab has that double down arrow. The timing of rituximab appreciably influences vaccine response, at least as measured by humoral immunity. Abatacept probably diminishes response as well. Tofacitinib in some studies, methotrexate in some studies as well. So the point is that some but not all of our medications diminish vaccine responses for the vaccines that are here. The cytokine inhibitors, not so much. TNF monotherapy, IL-6R monotherapy, and some of the newer drugs we use in spondyloarthritis don't diminish vaccine response much, if at all, and I'll show you some of that data. But the point is that some of these drugs do diminish response. So we last had vaccine guidelines in rheumatoid arthritis embedded in these 2015 guidance statements. And just by way of reminder, there's a general recommendation that before your patient starts any immunomodulatory therapy, you should vaccinate with everything that you're going to give them, because they're not on any immunosuppressives yet. Hopefully they're not on a bunch of steroids, but you should put in your head new diagnosis of whatever it is that you're newly diagnosing. And if DMARDs or immunomodulators are used, ideally vaccinate them right then before you start therapy, rather than 2 or 4 weeks later when otherwise you might start. They're probably going to get a better vaccine response. However, you're only going to be newly diagnosed as a patient with anything once. So for the most part, as rheumatologists, we're going to have to contend with, like, what do we do for somebody who's already on therapy? So that's then how we have to think about the influence of our medications. So I've summarized most of the medicines that were around several years ago, but to complement that with a little bit of newer data. So this is anti-IL-17 data. It happens to be ixekizumab. So we're looking at the tetanus and pneumococcal vaccines, both Boostrix and Pneumovax 23. So what you're looking at is in the rightmost column, it's the difference in proportion responding of the ixekizumab versus control. So in that rightmost column, anything that is 0 or better means that the ixekizumab patients do better than the healthy controls. So you'll see that a 4-fold increase to tetanus vaccination, or a 2 or a 4-fold increase in at least half or more of the serotypes, regardless of how you define it, you get the idea that all of those numbers are either positive or close to 0, meaning ixekizumab does not diminish vaccine response compared to healthy controls not on ixekizumab. Same thing here for influenza and the meningitis vaccine. So again, comparing to healthy controls, secukinumab, again, doesn't diminish response. That difference in proportion in the rightmost column doesn't really differ much from 0, suggesting that IL-17 medications do not do much to impair vaccine response. You'll also notice that the N's are small. Typically, for most vaccine studies, you don't need N's in the hundreds and hundreds unless you're powering for clinical efficacy. If you're powering for lab-based outcomes, typically 50 to 100 is about on par with what you would expect. And then for Tofacitinib, this is PCV13, this is Prevnar. So these are the 13 serotypes of the pneumococcal antigens that are targeted by the pneumococcal vaccine that we use. Really, there's not much of a diminished response. That y-axis is the proportion of patients responding, and you see that this is pretty close to 100%. These are psoriasis patients. These are not on background methotrexate. Now, again, think about what is it that we are vaccinating them against. This is not a virus. We're vaccinating them against, pneumococcal disease. So whether this is, more of a T cell or a B cell, humoral or innate immunity, I mean, some of those considerations are relevant, and that's honestly what makes it hard to extrapolate across different vaccines and vaccine platforms when it comes to what the effect is of our immunomodulatory therapies. Same thing with ustekinumab. Ustekinumab really doesn't do a whole lot. So again, consistent with this notion that cytokine inhibitors probably are not doing much to impair vaccine response. I mentioned that the high-dose influenza vaccine, is preferred, at least from a public health perspective, in older patients age 65 and up. This was an interesting randomized controlled trial of 279 RA patients. This is not older patients. This is now, standard clinic mean age, in the 50s, 60s, early 60s RA patients. What you see is that the group in orange that gets the high-dose flu vaccine does better, both in terms of seroconversion, defined as a 4-fold increase, or seroprotection. The orange group that gets the high dose does better on average than the lower or the standard dose. So as a practical matter, if I had the luxury to give high-dose flu vaccine to all my RA patients, regardless of age, based on the results of this decent-sized trial, I would want to do it. Now, probably you and I can't get that paid for very easily if they're younger than age 65, but would it be a good idea based on this trial? The answer is probably yes. One of the most important studies is the Korean PARK study, and I'll spend just a couple minutes because this is the one that will be quite important when we come back to what's said for COVID vaccination and what do we do about methotrexate. So the hypothesis here is that if you hold methotrexate around the time of influenza vaccination, you will get a better vaccine response. So the methotrexate continue group in white, they just continued methotrexate at the same doses, nothing changed. In the hold group, those people were randomized to discontinue. And what you see is that the response on the y-axis was greater in the people that held the methotrexate. That's the group in gray. That was statistically significant, that delta in the, the 14% up to 25% range. In my mind, that's a clinically relevant effect size, even apart from the p-values. So regardless of whether you define response as 1, 2, 3, or 4 antigens, it looks like if you hold methotrexate for two doses after you give the flu shot, patients are going to have a better immunogenic response. The other thing that I think was helpful that they did, they looked at whether there was a dose-response relationship. So here again are the 4 serotypes. And what you will call attention to is in the rightmost panel of each of these 4, that set of bar graphs is methotrexate at doses of 15 milligrams a week and higher. You'll notice that the statistical significance and the deltas are greater in that higher dose methotrexate group than the lower doses. And in fact, the difference is if you're on 7.5 milligrams or lower of methotrexate, that's the leftmost set of panels in each of these 4 regions, they're not significant and the deltas are much smaller. So the point is, it looks like holding methotrexate probably matters more if your patient is on higher doses of methotrexate and not if they're on very low dose. Now, some of the limitations to the study, this is a Korean study. I don't practice in Korea, and I don't think you guys do either. And Korean genetics, body weight, etc. I live in the South where fluffiness abounds in the South, and our vegetables are creamed corn and fried green tomatoes. So could dose and body mass index and genetics and lots of other influential factors limit the generalizability of this trial? Sure, it could, but nevertheless, this is probably about the best that we have. The other thing that gives people some pause is what are the unintended consequences if you choose to hold methotrexate for a couple of weeks, as was done in this trial. So in the methotrexate continuation group, 5.1% of people had a flare of their RA, and it was 10.6% of people in the methotrexate hold group. It wasn't statistically significant. The p-value is 0.07. I wouldn't get too hung up on that. You know, the flare rate's double. It's 11% versus basically 5%. They use the reverse DAS, so a DAS worsening of more than 1.2 units. This wasn't kind of a made up definition. So, I mean, I think it's a definition that people would nod their head and say, yeah, I think that was reasonable. But this is maybe the downside of telling your patient, hey, you should hold methotrexate for a couple of weeks, is that they may have a higher rate for flare. It's not a lot, but it may be noticeable for some. Let me then switch gears and then speak to pneumonia vaccination. So PCV13, so that's Prevnar, just because sometimes people don't know it by that name, and PPSV23, so that's Pneumovax. So this is what's recommended for adults with immunocompromising conditions, which is probably most of the patients you and I see and treat on a regular basis. So this figure essentially lays out what you should give them next. So in the top left, this would be pneumococcal vaccine naive patients age 19 and above with immunocompromising conditions. If they've never gotten anything, that's why none of these boxes are black, then you would give them PCV13 Prevnar. And 8 weeks to 1 year later, you'd give them Pneumovax, and if it's been more than 5 years, you'd do it again. If they've already had 1 dose of Pneumovax, then the next thing you would do is you would give them Prevnar as long as it's been a year. And then for the rare patient who had got 2 doses of Pneumovax, you would give them Prevnar as long as it's been these intervals. So when we showed this to our clinic staff and our nurse manager, she looked at this and she said, Dr. Curtis, this looks way complicated. There is no way we're going to implement that. I said, okay, how about if I make it really simple? How about over a 6-month or 9-month period of time, we just ask every patient, hey, have you gotten the pneumonia vaccine and was it Prevnar? And if they say, I've never gotten Prevnar or I don't know, we just give them Prevnar. Could you live with that? Like we're going to give Prevnar to everybody unless they say, oh, no, I've already had that one. She said, oh, I think that actually might be feasible. We could probably do that. So I'm a big fan of simple when it can be simple. And I think you can reduce this honestly to simple. And so the bottom line, if you're going to vaccinate someone who's never had Prevnar, just go do that. Like worry about what the next thing is next year, but do something. And most patients honestly don't even know what pneumonia vaccine that they've had if they've had one. And unfortunately, some of the direct-to-consumer advertising one and done, that's right for Prevnar, but there's a series here and they're missing the other 2 shots. So most patients don't know that you're supposed to get 3 over their lifetime. And at best, they might know they've had something, can't tell you what, can't tell you when. So bottom line, I'm a practical guy. I think if you can't tell me you've had Prevnar, then we should give that to you. And in a year, then now we'll talk about what the next thing is. But I think this is actually feasible to do in a pretty simple way. You might say, well, gosh, this looks complicated, even though I get that the message, at least what to do next, it should be simple. Why do we do that? So let me show you the sequencing data about why we give it in this order with this sequence, where different combinations of Prevnar, PCV13, and Pneumovax, the 23 group, were done. If you give one vaccine, the serologic response goes up some, and then it diminishes, within a year or so. So regardless of which one you gave, if you only ever get one, there's not much of an immunogenic response. And yet for most of our patients that have only ever gotten 1 dose, like this is where they're sitting. It's if you give Prevnar followed by Pneumovax, that's this red dotted line. This is why you need to give at least 2 doses, because otherwise your patient really isn't protected. So if you're missing at least 2 doses, if not all 3, they're sitting where my blue arrow is, and they're not going to be very protected. And unfortunately, as a country, we have not done a particularly great job doing this, despite the fact that these are quality measures. These are MIPS measures. So measure 111 is give pneumococcal vaccination, and that's not all 2 or 3. That's like anything ever. It was only about 2/3 of patients that got it that are age 65 and up. Flu was about 50%. There's not a measure for herpes zoster vaccination. This is back with when Zostavax was being used, and it's certainly lower for the at-risk immunosuppressed patients getting pneumococcal vaccination. So my point is that we're not doing great as a country, but I think as rheumatologists and rheumatology practices, we can do better, and I think that you can and we can implement within our practices a systematic approach to making sure that patients are vaccinated. If you chose this as one of your MIPS measures or two of your MIPS measures, then probably that will even further help shine a spotlight, and those certainly would qualify as some of the quality reporting measures relevant for rheumatology. So now let's switch gears and talk about Zoster. So of course, Zostavax, or the live Zoster vaccine, is live and it's attenuated. And we would all know that live vaccines should generally not be given with, and pick your favorite biologic. I pulled this directly verbatim out of one package insert, but they basically all read like that. There are a number of live virus vaccines. The adult herpes zoster or shingles vaccine by Merck was the most common one, I think, for adult rheumatologists. If you treat children, rotavirus would be relevant, and obviously some of these others. Remember that the varicella or chickenpox virus that has a much lower inoculum that's given to children, that's also by Merck. And then there's a handful of others depending upon travel, particularly yellow fever. So it looks like the vaccine campaign, particularly to treat children at early age with Varavax, that's the varicella live virus vaccine, is working pretty well, in that the incidence of zoster has decreased quite dramatically over time. This started being very commonly used in 2006 and then continued thereby. So the fact that you see all of those incidence rates dropping suggests that Varavax in pediatric immunizations is working quite well. And in the most recent birth cohort, 2002 to 2016, that's that green line on the bottom, the incidence rate of zoster is very low. So I would suspect that there will come a day when zoster is something that hardly anybody has seen for quite a long time. Unfortunately, I don't think I will still be practicing, because that day is almost certainly going to be 15 years and beyond the present time. But eventually, I think some of these public health measures in kids are going to be effective. But what do we do for adults? So by way of reminder, and probably something you all know, most of us, at least over the age of 35 or 40, have this virus living in us in your dorsal root ganglion. For healthy people, the lifetime risk of reactivation is about 1 in 3. Roughly, the event rates are 4 to 11 per 1,000 person years, and with immunosenescence, VZV specific cell-mediated immunity falls, and people get reactivation and get shingles. Roughly 15% of people will develop postherpetic neuralgia. Interestingly, particularly if there is cranial nerve involvement, there's actually about a 2.5-fold short-term increase in risk, both in the general population, and Len Calabrese and I studied this in RA patients. You have a higher risk of hospitalized stroke, but as you might intuit, it's only if you have cranial nerve involvement that that's the case. The risk for rheumatology, lupus, psoriatic patients, etc., was generally felt to be elevated, and VZV vaccination was recommended but uncommonly used, because initially, of course, the only vaccine we had was the live virus vaccine. So often our public health guidance for vaccination is predicated based on age. But as we started thinking about what should we be doing if it's not what the CDC tells us, maybe we need to be more aggressive. So what we did is we looked at population-based data, where we said at the time, there's general recommendations. You should be vaccinating everybody, in this case with Zostavax, age, above 60. So we said, well, the incidence rate of zoster in healthy people age, above 60 was 8.5 per 1,000. So we thought, what if we found other groups of rheumatology patients that have at least that or higher a risk of zoster? Because maybe we should be vaccinating to risk, not based on age. So this concept of vaccinating to risk might say, well, gosh, maybe younger people that are sick or on steroids or on immunosuppressed drugs, as long as you have the same risk or higher for zoster as this group in blue that should get vaccinated, then we should recommend to vaccinate those people too. So along those lines, we assembled a cohort of lupus patients, same data set. These are many thousands of people. And you'll see that even for women in their 20s, 30s, et cetera, they have double or triple the risk for zoster. So you might say, well, gosh, if you're going to vaccinate healthy people in their 60s and 70s, you should be vaccinating all of your adult lupus patients. RA, not quite as high. The red means a statistically significant increase. The yellow means it's not inferior, meaning it's comparable to the blue. So you would say, well, we should definitely be vaccinating RA patients in their 40s. So that's the concept I want to leave you with, is vaccinating to risk and getting beyond just sort of some of the age restrictions with shingles that we've dealt with. The other thing that comes up a lot is, what's the contribution of the drugs that we use? And initially there was a potential safety signal, maybe anti-TNFs increase risk for zoster. A meta-analysis, frankly, I think has mostly concluded probably not the case. What's not at all controversial though is prednisone definitely increases risks even at lower doses, 5 to 10 milligrams. The rates for the non-TNF biologics are quite variable depending on the molecule, but not a lot of consensus. What's not at all controversial though, and what put zoster back on rheumatologist radar screen, is the JAK drugs. So this is a comparative effectiveness study where we looked at the incidence rate for zoster. You scan down here, this is the rate per 100. So unlike the rate in healthy people where it's less than 1 per 100, these rates in an RA cohort are in 2 to 3 per 100 until you got to Tofacitinib, and that rate is 4.3 per 100. And once you do some multivariable adjustment, Tofacitinib doubles the rate for zoster. We then thought, well, gosh, maybe that's unique to Tofa. Not all the JAKs have exactly the same selectivity. When we looked at Baricitinib, if you look at that rightmost column, you'll say, well, gosh, that rate of 4 or 5 per 100, that's spot on with the JAKs. And for Upadacitinib, depends on the dose. But, all 3 of the approved JAKs that we have for RA double, if not closer to triple, the rate of herpes zoster. So it's not just a Japan or an Asian thing, it's pretty true across the board. And then we have the newest JAK, which of course is not approved, Filgotinib, for which the RA trial program was killed. And you'll say, wait, that's not a rate of 3 or 4 per 100, and yet that is a JAK1 selective drug. Why does this not have that double or even triple the rate of zoster? Shouldn't it be JAK1 selective just like Upadacitinib is? And yes, it should be, and yet it definitely stands as an outlier. It may be only a curiosity for us in this country, since this isn't a drug we can prescribe for any indication, RA or anything else. But anyway, I think that probably the JAKs are not all the same for the 4 that are here, but 3 of them stand together with respect to doubling or further increasing risk for zoster. Filgotinib is obviously the exception. So then let me switch to interventional studies. So given the focus on zoster and the fact that we had a live virus vaccine, people were just kind of panicked and freaked to use it if we were going to give people varicella infection or shingles, we said, well, why don't we do a randomized large pragmatic trial, put everybody on a TNF to test the hypothesis that it's not a dumb idea to go give people a live attenuated virus vaccine, Zostavax, if you're on a TNF. So we had 42 days of follow-up, because if you're going to have something bad happen, in this case, if you're giving them chickenpox infection, that would be the bad thing people would worry about. You're going to see it in that time frame. So we did some fancy things with respect to electronic consent, and we had the ability to take pictures of shingles rashes and swabbing skin with PCR to prove it's varicella and Oka strain, etc. So the trial is completed. 617 people were randomized. Half got Zostavax, half got saline. It's blinded. Everybody's on a TNF. We have blood and sample collection and follow-up. The short version is that your IgG goes up, your interferon gamma response goes up, the vaccine works at week 6 compared to placebo. And then perhaps the most important thing is this bottom row. The number of varicella infections, either Oka, which is the vaccine strain, or wild type, was 0 in the time frame in which you worry about it. So the concern about giving a live virus vaccine, at least to the extent that a 1-to-1 randomized 617-person trial can inform that, didn't seem to be borne out. The upper bound of the confidence interval for infection was up to 1%. So that's low, but it's still not 0. So based upon the results of this study, I think that last bullet, testing the hypothesis, maybe not all live virus vaccines are terrible ideas, and maybe TNF doesn't really immunosuppress you that much as might have been feared. What was helpful, of course, the importance of a Zostavax trial has been somewhat eclipsed with Shingrix. Let me show you, though, one more study, because I think mechanistically it's important. So in the Pfizer oral strategy study, patients could get Zostavax or not at the investigator's discretion. 19% ended up getting it. They then looked at whether people developed zoster, clinical efficacy, did it work? So in the adalimumab group, that's in red, the not vaccinated rate of zoster was, 2.5 per 100, much as you would expect. In the vaccinated, it was 0. I just put that little red bar just to make the point that I didn't forget to put a bar. But in the tofacitinib treated patients, it was exactly the same. So the idea is maybe if you're on a JAK, maybe vaccines that really need interferon, and especially interferon gamma, maybe those vaccines don't work as well. And maybe we need to not assume that this other vaccine, pneumococcal vaccination, that isn't much impaired by tofacitinib, maybe we can't extrapolate that to herpes zoster. And maybe we actually need to test that formally. So the world, of course, changed once we had the soap bark tree, which is part of the ASL1B adjuvant, which enhances glycoprotein E specific antibody. And of course, this is Shingrix. FDA approved in 2017. It's not explicitly approved in immunocompromised patients, but unlike Zostavax, it's not contraindicated and it's not a live virus vaccine. Perhaps surprisingly, it got a preferential recommendation over Zostavax in a very controversial 8-7 vote. And the controversy was, there's no real world data. How can you recommend that over a vaccine that we've had for, more than a decade? But on the upside, this vaccine, Shingrix, works pretty well. 90-ish% efficacy, is pretty great, 91% against post-herpetic neuralgia. It doesn't work quite as well in hematopoietic stem cell transplant or renal transplant patients. Those are people on cyclosporin, and now we're starting to get to some of the medicines we use. But this vaccine works much better than Zostavax and certainly flu. The thing that I always remind people is the incidence of systemic, especially grade 3 reactions. So if you look at the height of the red bars in the Zoe 50 trial, in the second and the fourth panel, roughly about 14 or 15% had grade 3 systemic reactions. Fevers, myalgias, joint pains, you don't go to work, you don't drive carpool, you don't take care of the grandkids. Usually after I give most lectures, at least in person, a physician would come up and say, I was one of your 15% that had this terrible reaction after I got Shingrix. I'm glad you reminded people of that, because if you don't tell patients about this, they may be calling your office thinking they have a flare. You just need to give them a couple days for it to calm down. But to prepare them for this, the other risk is that if they develop this with the first dose, they may not be keen on getting the second dose. And if they don't get the second dose, they're almost certainly not protected, or not protected as well. You have to refrigerate and reconstitute this. You can give it with another vaccine, not COVID, but the others. If you miss the second dose in the 2 to 6 month window, you should just go ahead and give it. You don't have to start over. It's totally fine if you've gotten Zostavax in the past. And when you might need to vaccinate or revaccinate is totally unknown, because you need data for that. I suspect that at some point you'll need to give a booster, but we don't know that yet. And importantly, in my mind, it's rather unknown because of what you need with respect to interferon signaling, whether Shingrix is going to work all that well if you're on a JAK. We don't know that. So the important part of that is both whether it works, and then this bit at the bottom, the potential risk for a disease flare. And if you have systemic reactogenicity, if you're one of those 15% that feels terrible, maybe you don't get a second dose. You also cannot just check a varicella zoster virus ELISA or any other lab test to think you're protected. That can't be done. And there's some small concerns, like with most vaccines for Guillain-Barré, but that's quite rare. With this vaccine, as with COVID, there's always a concern about disease worsening or flare. There have been case reports, and just to pull out an example, 30-year-old woman with psoriasis, she had less than 2% body surface area. She got a flu shot for the first time. This is what she looked like immediately thereafter. This is not less than 2% body surface area. This would be terrible. Again, this is case report. So, could this happen? Sure, it could. Does it a lot? Probably not, but it has been seen. So let me skip then to a large pragmatic trial that was about ready to launch until COVID hit a year ago, where we basically would be looking at RA and ulcerative colitis patients on a TNF or TOFA, that we would be giving them Shingrix, and hopefully, in the next year or so, that, and COVID, diminishes perhaps a bit in importance, this study will be reinvigorated because we put it on pause a bit in light of this. Of course, this is now occupying everybody's time and attention. So the ACR convened a task force that, as Namrata said, that I have the privilege to be able to lead and work with a lot of other smart folks, where we used a modified Delphi process to basically do generate an evidence summary. We got 9 rheumatologists, 2 infectious disease docs, and 2 CDC public health experts to essentially do a literature scan of all the available literature for all the prior ACR COVID and, all the ACR guidelines in the past, non-COVID vaccines, and then a literature scan of all the COVID vaccine literature in non-rheumatology patients, and then come up with a series of rating statements that totaled 74. So this is the document that was released in the last week or so. And just to point out a few of the highlights here that I have in bold. So, based on their risk for COVID, autoimmune and inflammatory rheumatic disease patients should be prioritized for vaccination. That's the third statement that had moderate consensus. The expected response to vaccination for the 2 mRNA vaccines may be blunted both in magnitude and duration. The task force acknowledged the risk for flare or disease worsening. I basically showed you at least this theoretical risk, but not to dissuade people from getting vaccinated. The benefits almost certainly outweigh any potential risks. Probably the most important statement is the first one right here now on this slide. If you have a rheumatic and musculoskeletal disease or an autoimmune and inflammatory disease, those are those 2 abbreviations, you should get vaccinated, hard stop. Not children under age 16, because that's not consistent with the emergency use authorization, but you should just get vaccinated, even though there's no data. It was very interesting to see what Canada did. Canada basically looked at the Moderna and the Pfizer trials, said, wow, rheumatology patients, immunosuppressed patients, they weren't really represented. And therefore, rheumatology patients in Canada shouldn't get vaccinated against COVID, because in the absence of data, we just think that's a bad idea. And to me, that was rather appalling, because our patients, are at least as at higher risk to develop COVID and have bad outcomes. No preference for one COVID vaccine over another, something that is somewhat controversial and I suspect will evolve. At this moment in time, there's not solid enough data about ordering lab testing for antibodies against spike or nucleocapsid to assess immunity or the need for vaccination. So I had a lot of people quibble about that, because they sometimes are finding that helpful, but unfortunately I think that the devil's in the details about what to do with the result. And then, consistent with some of the data that I showed you about maybe it's better to hold some of the therapies, particularly methotrexate, there was a recommendation to hold methotrexate, not for 2 weeks like the PARC trial, but only for a week, because honestly, this was where simplicity rather carried the day, where holding 2 weeks after each of 2 doses, where you give methotrexate, 1 or 2 doses in the middle, that was just so complicated that it felt difficult to message to patients. And then, given the possibility of a diminished vaccine response with JAK inhibitors or abatacept, you can read the recommendations to hold there. And then some additional nuances with respect to abatacept, cyclophosphamide, and rituximab. And then lots of overriding principles and assumptions. And the third one is maybe the most important. There's no direct evidence about mRNA COVID vaccine safety, but again, on balance, we would expect that the benefits for our patients would outweigh the risks. And within probably the next 90 to 120 days, we hope to launch a very large-scale multi-site study that, if one or more of you would be interested in participating in, would love to chat with you further about that and hopefully be able to collaborate around that. So with that, we're at about 1:45, and I do want to leave time for comments and questions. Thank you so much for your time and attention. It looks like there are some questions, and would certainly be happy to field those from any of you.
Thank you, Dr. Curtis. That was amazing overview and a lot of information. Thank you. Do you want me to read first question, or can you see the question?
No, I'm happy to see them, so wouldn't put you to that. So one question about if the regular dose vaccine is a reasonable choice, but what if you could give 2 doses? If you couldn't give the high dose or the adjuvanted, wasn't available, or you couldn't get it paid for. So I think that's reasonable. The idea being, give the regular vaccine and then expecting that it's going to give you some benefit, and then you could boost it. There's not data, of course, in rheumatology patients of any size. I think, though, we would expect that depending on when you give the first dose, it's going to attenuate, and patients that are vaccinated, in September have probably lost most of any protective effect come February or March. So I think that's reasonable, but we just don't have a lot of data available to support that. The next question that I'll paraphrase, at what dose of prednisone can I get vaccinated for COVID or some of these other things? So this is a great question, and let me just make it a little bit more general. And let me go back to the statement that is of relevance here. So it's this second bolded one, 1, 2, 3, 5 down. So there's a lot of words, but let me just give you the concept. The concept is, if you're on a highly immunosuppressive regimen of steroids, a mg per kg of steroids or any other bad thing that we think might attenuate vaccine response, is it better to vaccinate right then and there and hope that you're going to get some response? As long as it's more than nothing, then fine, then that's probably a good idea. Or is it better to defer vaccination, let's say 3 months, with the hope or expectation the patient will be on a lower dose of steroids at that time and maybe not on cyclophosphamide or whatever it is that you are worried about that might impair and attenuate vaccine response? There's not a right answer here. As long as there's not a safety concern. So the timing is really predicated on maximizing or optimizing vaccine response. So if you're in the camp that says it's better to get something versus nothing, you should just go vaccinate right then. Because again, it's not a safety question, it's an optimizing efficacy question. On the other hand, if the person is at low risk for COVID, they're doing physical distancing and all the other things, and if there's reasonable expectation that a bit down the road, 2-3 months, not crazy long, that they won't be on those medicines or at least those doses, and you can afford to wait, that might be preferable, but that assumes that the person's at low risk for COVID, doesn't work in healthcare, is able to physical distance, etc. So in the absence of data, of course, with which there is none at present, at least not direct evidence, I think either is a good idea. The task force basically mostly came down on the side of it's better to vaccinate now, at least with some response, than to defer where you might miss the window of opportunity. And if you're deferring, then at least in the short term, you have no protection at all, and it's better to have something versus nothing. Now, what would be delightful is if in 3 or 6 months, you could measure, quantitative IgG and somehow use the result that you knew what to do with to say, aha, now it's time I give a booster, or now it's time I repeat the series. And because my patient isn't very protected, we don't have that lab test. We certainly don't have the ability to revaccinate people with any degree of alacrity. So that would sort of assume that, doing it now, you could try again in a while down the road, and we don't have that option yet, but I suspect that we may at some point. A third question, I have to be on steroids at or below 20 milligrams before vaccination. So again, the variability, and I'll point out the dose here. So at greater than or equal to 20 milligrams, there's no vaccination, no modifications to either immunomodulatory therapy or timing. That had a moderate recommendation because of this controversy. That said, if you look at the top row, it would be better to be on lower doses. There's nothing magic about 20 milligrams. That the CDC's used that for a long, long time based on some really old studies. So lower is better, but not if it's at the risk of delaying vaccination into in a meaningful way. There was a question about a prior auth regarding giving Shingrix before Tofacitinib or presumably any other JAK inhibitor for younger patients. So I don't know any policy level advances in that regard, except that the ACR guidance recommends that you vaccinate for shingles starting at age 60 and even 50. Shingrix isn't specifically mentioned because when it was updated in 2015, the only thing was Zostavax. So that's somewhat weak compared to what I think you would want. But in as much as the ACR recommends 50 and above, that might help you in the 50 to 64-year-old range. There was a question, does COVID vaccination reduce the risk of the spread of COVID? Well, it definitely reduces the risk for COVID. And unlike, the 10 or 20% for flu on the low end or 50 to 60% on the high end, 90 to 94% effectiveness, with Pfizer and Moderna's vaccine, that definitely helps. If you're not getting, COVID or severe COVID, then presumably, you're not shedding it. Does COVID vaccination reduce asymptomatic shedding or carrier status? I don't think anybody knows that, even in non-rheumatology patients. Mark asked about the strong recommendation not to measure COVID antibodies. So If you get no spike response, having measured that, yes, I think that could make sense. On the other hand, like, what's the number needed to test to find people that have no response? I mean, if you have data on that, I would love to see it, because nobody knows anything about that in our immunosuppressed patients. Most people have a response, and where the arguing is like, how much of a response? It's that whole controversy. Is it 2 or 4-fold, or is there some absolute threshold? So, in talking to some of the people who invented these tests, including the woman at LabCorp nationally who created theirs, and I said, is there an absolute or a fold rise in the level of protection for your or anyone's test that you believe has a reasonably good correlate at a person level, not a group level, but a person level of being immune? She sort of smiled sheepishly and she said, no, like I can make a bridge between my test and neutralizing antibody, and probably neutralizing antibody is closer to a lab correlate of protection, but no, not really. So I like where you're headed and the principle makes sense, but I don't know that we have the data to warrant that routine testing. And I'm not certain, but if you have data, would love to see it. If large numbers of highly immunosuppressed patients, aren't bumping at all their spike antibody response, sure, that would be important. I just suspect that that's not the case. Belimumab altering response, there's not much data for the other vaccines, but what we know for those, is probably it doesn't impair that much. The new study that I described to be launching would hopefully help address that, or one that Ken Kalunian and others are doing, where they're trying to get that arm funded. Right now, it's going to be lupus, mostly on mycophenolate. Rituximab. So I liked your paraphrase, what about giving the COVID vaccine now with something better than nothing? And I think that is really the heart of what I've described. It's better to do something now than nothing, as long as you expect you're going to get something. So the full paper that is under review at ANR essentially just lays out this in detail, hopefully not ad nauseum, but to say, if you can afford to wait, if you're on a 6-monthly Rituxan schedule, you would ideally probably want to give the vaccine at about 5 months, which would be a month before the next cycle ensues. What if your patient's not there because life happens and she got it a month or 2 ago? It's the argument that you've just laid out. If I do it now, I might get some response. Hopefully it's more than nothing. And it's better to be a little protected for a few months than not at all protected. On the other hand, are you sad then in 3 months when she didn't get COVID, but now you think, gosh, now if I had vaccinated her, she might get a lot better response and it might last longer, would be more durable? Maybe, you just don't know. The paper lays out this exact example to say, if you have somebody in low disease activity who does a lot of physical distancing, is at pretty low risk for COVID, doesn't really bother him or her to abide by all the preventive health measures, doesn't work in healthcare, it might be reasonable to defer a couple months until you get to that point where you're a month before the next cycle. But for the average patient where you can't have all of those criteria in place, probably just go vaccinate now. That might be the kind of patient that you want to check antibodies down the road, assuming we know what they mean, and give a booster or just redo the series. Do you think an ACR committee would allow there's no reason to expect harm as a stand-in for data in other situations, and does it set a poor precedent? So that's a great question, and that's sort of a philosophical thing. And in fact, when I got asked to even be part of this, I said, in some sense, a bit of a paraphrase about what you just asked. Like, why would we want to go tell people a bunch of stuff that's all extrapolated from our vaccine literature for other vaccines, and extrapolated evidence from what immunomodulators do for other kinds of infections? And this is going to be some thoughtful people spending a bunch of time to review other literature for other vaccines, and then giving our best guess. Like, does the ACR really want to be doing that? But the response I got from the ACR was, it's better to say something, even if it's based on imperfect evidence with very little direct evidence, than to say nothing when everyone's just making it up. And at a minimum, even statements like rheumatology patients should get vaccinated, prevents things like what I described in Canada, where they said, oh, there's no data and nobody said anything about it. So I guess your patients cannot be vaccinated. I also had a physician write in for the town hall tonight that said their patient showed up at CVS and was told by the pharmacist that they can't get vaccinated with the COVID vaccine because they're on a biologic and they must stop the biologic and wait 90 days. So I think you have craziness like that that ensues if people say nothing, even in the absence of direct evidence. So, I'm the first to point out, hey, we're flying in an evidence-free zone. Some of those guidance statements, in fact, make that very explicit, I hope, but I think it is helpful to curb some of the crazy things that otherwise might ensue, like the two examples that I just gave you. I think I mostly hit all the high points, but Namrata, if there's others that you see or anything else that people want to go over, I know we're getting down to the end of time.
Yes, no, you were spot on all the questions. Thank you, Dr. Curtis. And just a plug I'll put in for the ACR town hall that Dr. Curtis will be at later in the evening, 4:30 p.m. Pacific time, to discuss the new guidelines. So if lingering questions on the COVID vaccine guidance document, he'll be again available at 4:30 Pacific time for the ACR town hall. Thank you again, Dr. Curtis.
Thank you, I appreciate it.
Yes, thank you so much. And this lecture has been recorded, so we'll post it on our website as well. And thank you everyone for joining us.
See you in a bit, Dr. Curtis.
Okay.
Bye.
And